we're going to swiftly move on to the next panel that we have going on right after here, hosted and moderated by none other than Nathan Sondheimer, who's actually part of the panel for the Women's Health Tech Innovator Showcase that we just had now. So I am going to pass it over to Nathan in just one moment, and he was going to introduce his panel that's going to discuss the role of patient-generated data in the population health management. So really looking forward to that, Nathan, and I'm going to bring your panel on board so that they can start this wonderful conversation that I think we would all definitely love to tune in for. So thanks again, Nathan, for coming on. I hope you still got some energy after those whirlwind presentations just now.
Absolutely, yeah. Thank you so much, Jerry, and hello, everyone. Once again, I'm Nathan Sondheimer. Glad to have you all here with us today to learn a little bit more about the role of patient-generated data in population health management. And as we bring on our panelists for today, I do want to mention that we do have a lot of points to discuss, but we also want to keep it really engaging. So if any of you in the audience have questions throughout our section, please feel free to throw them in the Q&A, and I'll try to integrate them in. But without further ado, I'd love to have each of our panelists introduce themselves and briefly tell us a little bit more about their respective organizations. So to kick us off, I'm going to turn it over to Howard. How are you doing today, Howard?
Oh, fine. I'm more wondering how you're doing. You're sort of doing a yeoman's job of the chair emeritus of these sessions.
Wonderful. Thank you.
Yep. Thank you very much. Very quickly, again, my name is Howard Rosen. I'm Principal Nova Insights and founder of LifeWire Corp. Very quickly, in terms of background, as educated as an MBA, International Finance and Marketing, trained to run a Fortune 500 company. Unfortunately, didn't seem to happen out of school. So naturally, I spent 20 years producing film and television, which is a natural segue into health IT about 15 years ago, which was inventing a platform called LifeWire, which is basically a patient engagement platform. We work with clients in terms of payers and providers across the United States, dealing predominantly in the behavioral health area, but really being that interaction between patients and providers.
Awesome. Thank you. Yeah, thank you. And I'm going to turn it over to John now. How are you doing today, John?
Well, Nathan, thank you very much. I'm glad to be here today. Excited about the panel. My background is in epidemiology. I'm trained as an epidemiologist. I'm on faculty actually at Columbia in the School of Public Health, where I teach pharmacoepidemiology. And spent most of my career though focused on building real world data platforms and demonstrating value of pharmaceuticals and medical devices. I spent about 12 years at IQVIA, a big data company in the pharma space, and then moved on to Pfizer, where I led healthcare innovation. And in that role, started to work with digital companies. We had a collaboration with Fitbit, for instance, and also partnering with healthcare systems, essentially to deploy digital technology to generate real world data to evaluate benefit, risk, and value of medicine. About 6 months ago, I joined Exponent to lead health sciences. And this is a company based in Silicon Valley doing engineering and consulting work for a lot of the big tech companies. And I've been working since then with pharma companies to essentially help them strategize on digital technology optimization for R&D, all the way through commercialization and real world evidence generation.
Thank you. And last but not least, Joao. Good to see you, my friend.
Hi, guys. Yeah, nice to be here, Nathan. Nice to see you again. And nice to be connected with you all. For some reason, I'm not coming up. Is my video on?
Yeah, we can see you.
Oh, you can see me. Okay, brilliant. Nathan, nice to see you again. You seem to have a busy day and another panel for you. So delighted to be here. João Bocas, I'm the Chief Exec of Digital Solutum. We are digital health experts. Personally, Portuguese, based in UK, global citizen, and I have two passions really, which I believe they kind of interlink. I have a background in professional sport. I was a sportsman for a number of years, and then I entered the corporate wellness. Always been interested in health and fitness. But the last 15 years, I've been heavily involved in digital health innovation. And the last 7 years, highly focused on wearables, digital health. And now with my company, we are on a mission to make healthcare uncomplicated with digital transformation in healthcare. So delighted to be here.
Awesome. Thank you. Well, with that, let's get into the meat of the conversation. So as we all know here, like one of the universal pillars of focus, and especially in healthcare innovation, is improving patient outcomes. And especially over the last 18 to 20 months, we've really seen an increase in solutions and methodologies to augment preventative care and reduce non-communicable disease as a part of population health management. However, as we know, the effectiveness and the success to this is often dependent on patient engagement. So through each of your lenses, I'd love to understand what has been going really well in terms of patient engagement, and what are some of the next big objectives we should look to achieve to really augment the capabilities that we're already working on right now?
I could start that if you want. Nice to start with an easy question. So that's the 4-hour short version. It really, in short, in terms of engagement, and obviously it comes from the area that I've been involved in, is to, in terms of engaging, you want to reduce the barriers of engagement. So the fundamental piece that's been successful for us has been reducing the barrier by, instead of telling patients how to communicate, they're the ones that initiate. They choose how they want to communicate. So whether it's going to be on their computer or your cell phone or a laptop, even a landline, or whatever device that they have, let them be the ones to sort of use the fundamental means that they're most comfortable with. Because once you reduce that first barrier, then it become easier to start with. But if you start saying you've got to download this, you need this device for that, depending on the where they are in their technology world, it's a very quick way to prevent them or to have that initial reason not to do something. So as a fundamental, it's let the patient choose how to communicate.
Awesome, thank you. John, go ahead.
Yeah, sure, I could jump in. I think we're doing a really nice job in measuring physiology with digital technology, sensors and wearables and the Internet of Medical Things. And, speaking from a pharma company perspective, I think there's a lot of interesting exploration of deploying that technology in clinical trials to do a better job of essentially being patient-centric. You hear a lot about patient-centered drug development. Well, digital technology is equipping R&D teams with tools like they've never had before to be more patient-centered. So I think that's going well. Where I think we could get a lot better is if you think in terms of Maslow's hierarchy. Physiology is at the base of the pyramid. It's just sort of the basics. It's just understanding functionally how we're doing. Next up will be in terms of how patients interact and consumers interact in the real world, and how they operate and what their activities of daily living look like, how they socialize, how they work, how efficient they are when they work. So I think this next level of engaging with consumers / users / patients and how they operate in the real world with their environments and with each other is the next hurdle to overcome in truly understanding their experience and measuring it.
Thank you. And Joao?
Yeah, brilliant. Some great points there. I do agree with Howard about let the patient kind of decide how they want to interact. And John mentioned wearables. And what I've been seeing is that health accessibility, the awareness is greater. Everyone has got they're more aware of their health, about accessing these digital tools, gadgets, wearables. But also I'm seeing quite a few barriers from a patient perspective, and I've done a lot of work on wearables. The long-term engagement seems to be an issue, and it seems to patients need to understand, well, first of all, the value of using the device, because most people, what I'm seeing now, are two main streams in here, the fitness side and the health fanatics, and then let's say the medical side of things. But the ones they're more prone to keep using the devices are the people that generally are more healthier and they're more self-motivated. So we need to close the gap in terms of educating the ones they're not perhaps so motivated, how they can kind of make the most out of the device, how they can kind of relate to what is important to them, because a lot of wearables, they bring 6, 7, 8, 9, 10 data sets, and it might be only one that is relevant to you. For example, a few years ago, I was very interested in my steps. I'm not interested in my steps whatsoever right now. I'm interested in my sleep, you know, but that might be different to Howard or to you, Naifed, or to John, you know. So it's important to kind of find an intrinsic motivation. And one last point that I would like to bring to the table is the devices in developed countries, it might be accessible for us. Let's say an example, Apple Watch might cost $400. Some of us, they might have access to that. But in non-developed countries, $400 is a lot of money. If we go to South America and third world countries, how you can even consider having a wearable if you don't even have access to healthcare in the first place and there is no internet around. So there are still major barriers around the world that, in terms of inequality to use these devices. For most of us, it's kind of norm because we are embedded in this industry, isn't it? This for us is day in, day out. We discuss innovation and see things evolving. But for some people that perhaps are less favorable in one of these countries, even having a device, it seems like an unattainable task. But anyway, I'll leave you with that.
Thank you. And just to kind of drive on to one of your points a little bit further, and as you said, it's kind of the big challenge. It's not getting someone to use these technologies first couple of times. It's really that prolonged engagement. So with the different solutions that you've seen or come across, what are some of those tactics, or what are some strategies that you've seen that some wearable companies have used or some wearable technologies employ that really sort of encourage or really drive more engagement long term?
Great point, Nathan. I've seen one of the gaps being the behavioral change piece. So, for example, Fitbit, before they got acquired by Google, they actually bought a coaching company, and there is a reason for it, because the miracle is actually in the change of behavior. Okay, I could put a device on my wrist, and so what? It's like being a member of the gym. I can be a gym member, but if I don't go and work out, I will not get the benefit. I can call myself a gym member, but that doesn't mean I am fit. So I see these strategies about also in rewarding good behavior and health behavior. There's a company here in UK, I strongly advise you to follow the model, called Vitality Health. They've done a lot of work in rewarding the insurees with good health behavior. Now they have partners, you might get a free coffee every 2 weeks, you might get a cinema ticket, but also with wearables, now you get discounts on your premium and everything. So I've seen companies now trying to find ways to reward good behavior, and that seems to work. But again, it goes back to those that are engaged in the first place. So
yeah, if I could jump in too on that, it's a great question, Nathan, and Joao, I really liked your response. We've run into this as well, and this is in the public domain, so I could discuss it a bit, but we're doing some work with the Department of Defense running a wearable study at West Point. And we went in thinking, as well as the other study designers, that where else are you going to get great adherence? You got cadets that follow the rules, right? And so if we're going to give out Garmin watches or some type of wearable technology, and we're going to measure physiology and COVID transmission, et cetera. But what we found was that adherence wasn't great. And we had to take a step back and deploy human factors experts, behavioral scientists, to really understand, what was the resistance? What was it stemming from? Why were the cadets resisting using the watch at all times and being tracked? You can imagine there's some there's some intuitive reasons there, but it came down to demonstrating to them why we were doing the study, what was the objectives of the study, and what were the potential benefits conferred to an individual as well as to the population, to the greater good, the public health outcome that we're trying to achieve. So those factors, going beyond just the standard, here's the transaction of using this wearable, but more about the motivation behind the long-term health outcome for you as well as to your community, was critical in improving adherence in that particular study.
Oh, that's great insight and interesting, John, because my first clients in the area was actually the VA, where actually I had hair to start. I didn't know any better about working with that amazing population. But to your point, we actually found those same kind of results. And in terms of the engagement, and Joe, to the ongoing engagement, was actually providing feedback. So it's not just the device providing data, you're not a vessel, but actually providing feedback that's specific to the individual. So it's not just you've walked 10,000 steps or 4,000 steps. It's what tied to what they were doing that was more tied to their specific needs that related to them. And that relatability, again, the military was phenomenal with that, is we worked with different branches and found very strange responses from the individuals. And more of it became that they can tell from the feedback or the messaging, using text messaging as an example, whether the responses, automated as they were originally created by a peer who understood their issue or somebody in a white lab coat. And so what we worked a lot was with focus groups in developing the response mechanisms and sort of the AI tied to it, so that they understood that these focus groups had an influence. So they understood that these are peer-related responses tied to their needs. So to your point is relatability. Okay, someone understands my issue, they understand my need, and they're a peer.
Yeah, what a great comment. And yeah, I mean, obviously the VA has been progressive on this before just about anybody else in terms of testing wearables and even telemedicine, as we know. But just to validate your point, in our study, we deployed a technologist to help the cadets from a tech standpoint, and we thought that would be enough. As it turned out, to your point about the white lab coat and the peer, they actually wanted to talk to a scientist about why they were doing the study and the value of the data that they were generating. Great point.
Very quickly, I'll jump in as well, Nathan, very, very, very shortly. I've done a 159 pages health engagement report around wearables, and one of the user barriers is actually personalization, which Howard just mentioned is one of the top barriers, because in general, we devise to everybody, isn't it? I mean, we have a wearable, it's got the same features, it's got the same capabilities, and everybody's going to use the same. So, and every user is different, isn't it? As I mentioned before, I'm interested in my sleep. John might be interested in his performance activity, for example,
Absolutely. And I do have a kind of a point that I'd love to kind of combine both case studies from Howard and John. But before that, there's a question from the audience, John. And regarding West Point, how did you measure adherence? Was it medication adherence, or was it actually device adherence? Like
it was device adherence. It's a great question. Yeah, usually in the pharma industry, you hear adherence and it's adherence to medicine. But what's interesting is that these tools can help boost adherence, but you also have to consider the adherence to the technology. And this is where I found, in many regards, the med device industry has trailed a bit in terms of real world data from pharma. But this is where they flip the script, because the med device industry is deploying these wearables and sensors as part of their devices. And I think that they're testing different adherence strategies. And so I was speaking to adherence to the tech.
Awesome. Yeah, I'd love to pick your brain a little bit more on real world evidence, especially when it comes to demonstrating that sort of value. But before we get into that, this is more just out of pure personal curiosity, but if you're talking about West Point and you're also talking about the VA, I think it also brings up a pretty good question, which is like, how do you merge the episodic care model of like the in-hospital environment, such as the VA, with the continuous care model with these certain devices, especially when it comes to like remote patient monitoring and population health management? How are you guys seeing that you can combine both?
Sure.
Go
Well,
ahead,
it's an
John.
insightful question. I'll comment quickly and hand it to Howard. But the area where I focused when I was leading innovation at Pfizer was integrated delivery networks. These are the institutions that have that holistic care model, right? Because often they're at risk with their population, and the integration is primary, secondary, tertiary care. And if you look at, and track the news, you'll notice organizations like UPMC, Pittsburgh, and Ochsner in Louisiana. There's many others, but I'll just call it those two. They're doing so much in their community to equip their community to be better linked with their institution. They're helping patients get mortgages, for instance, with the government, because they discovered that patients that don't have housing concerns stay out of the emergency room and lead healthier lives. And they're just doing a better job of using sensors and wearables and the Internet of Medical Things to stay connected with their IDN. In those cases, their IDN has such a homogeneous kind of catchment area where they own a community. It makes it a little bit easier and more analogous to those cases of the VA in the West Point.
Well, I just was going to say, in terms of the utilization, we did the VA and in terms of the federal space and the commercial space evolved to the same, where really the idea is the relationship is outside the facility, an ongoing relationship. And it's really that ongoing communication. The idea really is to de-escalate any acute situations, actually to avoid them from going into the facility themselves. So we work predominantly in behavioral health and mental health, like post-traumatic stress, high-risk suicide, substance use as the initial utilizations. And it was that ongoing discussion, for lack of a better term, when they're outside that facility from their visits every 3 months, that they actually had this ongoing relationship and frankly, keyword outreach and notification. So the facility or the PSW, whoever, knew what was going on when they wanted to know. But the veteran themselves or the patient had this ongoing communication. And so either one could communicate with the other when needed. The idea was really not to be a periodic or episodic, but really this ongoing communication. Crucial, therefore, is that ongoing engagement.
Awesome. And then, I mean, yeah, because we're always talking about, we've mentioned community a number of times, and obviously that's a really big part of making sure that there is that certain level of adherence, and also making sure that there's that prolonged usage. But I mean, as Joel kind of mentioned before, there is quite a few limitations, and I mean, obviously you need to have an infrastructure, you need to have money, the devices, education, so on and so forth. But in your different realms, have you seen any sort of like lesser known technical challenges that pharma or providers may have experienced when sort of constructing an infrastructure to support these sort of communities in those efforts?
Just a quick example to the point that John had brought up, and your great question, Nathan, was we actually worked with indigenous populations in the Northwest. And what was interesting is, for those who were on the reserves, they all had cell phones, but none of them had cell packages. They actually, all they could use them for was going to the local Dunkin' Donuts, for example, the library, and use the Wi-Fi element of that device to communicate. And so in terms of as a limitation, it was a massive limitation in terms of working through how you create that relationship with that very limited technical piece that sort of Joe actually suggested earlier.
Yeah, I could weigh in too on another challenge, just to acknowledge Howard's point, though. I think that is critical, and it's such of keen interest to multiple players in the healthcare system now, trying to achieve better equity with regard to access to care and access to medicine. So I do think that the wearables and the sensors are going to help, but we have to be thoughtful about deploying them in an equitable way, because not everybody has access to broadband, for instance. The other challenge I was thinking of, and when I was reflecting on, where do we run into some roadblocks, it was data driven, as you might imagine. One was interoperability. So you create all this interesting data flow with sensors and wearables, and then you need to link it to clinical data. You could do it through claims data, electronic health record data, pharmacy data, administrative data, but you have to link it to make it valuable, really, right? So building this holistic 360-degree view of the patient, as much as we talk about it, it's still very challenging to do at scale. Some of these integrated delivery networks, like I mentioned before, they're better at integrating their data, not just their systems. So it's easier to plug in digital and sensor data there, but not plug and play. And the other area would be just lack of enough data. If you're going to build predictive algorithms with using AI and ML, very data hungry, and using small data sets from one institution, if you're looking at a rare disease, which I've looked at before, is exceedingly difficult because you just don't have enough data to predict diagnosis. So then you're left with the challenge of, okay, I better look across institutions on back to the interoperability challenge of trying to connect disparate systems. So data, in summary, has been a major roadblock to deploying some of the digital technology.
Got it. Thank you. And it's interesting you mentioned that, because it is kind of a question I also had for Joao, especially on the device side. And we're talking about, we have all this data, we're able to capture all these different points. Sometimes we don't have enough in a certain area for it to be quite actionable. But are there certain types of data that's out there that you are trying to capture, pharma's trying to capture, that it's just currently escaping us, but for whatever reason, we're not able to either generate enough data in that respect, or like we're just not able to capture that data, period, through a wearable at this point in time?
Well, great points. I have to go back to John's point, because interoperability was actually the #1 challenge in my report in terms of device related barriers. Because I mean, you getting the data is one thing, but then integrated in the clinical workflows or in your systems is a completely different thing. And actually, I was at another event today, and I was just giving an example. I live in UK. I love the NHS. I living in here. Nobody forced me to be in UK. I could be somewhere else. But for example, even in a country like the United Kingdom, the electronic medical records are not integrated. If you go to London, you have an accident in Manchester, your health data will not be accessible to the doctors. So now we're talking about wearables and we're talking about a separate thing, but just a basic thing that, I mean, for example, if you go to Nordic countries, they're much well ahead than I believe us in UK, and also you guys in the United States. But I want to bring a couple of things with regards to wearables. People are often concerned about their privacy. Okay, so is a barrier there? Okay, you're going to get my data, but what are you going to do with it? So getting in our wrong hands, and we hear a lot of stories in the news all the time about personal data, and health data is very delicate. The other point that I want to bring is that actually in here also we have another big barrier, which is the proliferation of data. We're getting too much data. Okay, I get a device, and clinicians, they don't have actually time to go through the data. If you have an appointment for 10 or 15 minutes, you can't make sense of the data. You can't treat a person and say, look, this is what I've been seeing in your trends for the past week or the past month. Or is no time. We will get that with AI in a couple of years' time, but we're not quite there yet. Also, the other thing is the industry doesn't have standardization. I mean, what is good data? Okay, now we have the medical device regulation, and we have these wearables that are better than those, and the medical devices, we can rely on that. But there are so many things in here that we have to overcome to actually be in a position to say, actually, this is what I'm going to do, focus on that particular aspect. There are so many things, because the industry is quite new in its own right, isn't it? It's a new kind of, I call digital health, which my vision is that absorbs the old healthcare industry. But this is a segment of digital health, and we all learning. I'm certainly learning, and this is all new, isn't it? This is kind of very actually, John mentioned concrete examples in his work, but very few people actually done some work around this and have concrete examples. Okay, John done that, and you know that these cadets, they're not engaging for that reason. But very few people actually done stuff around this, which is very new, is novice for all of us.
It's certainly opening up the world of all the devices, but there's so many points you guys have brought up in terms of privacy. One thing I've found in being a father of different age kids, privacy is actually generational from my experience. Like depending on that age group they're in, they have different concerns about privacy. Some who sort of just expect to have no privacy at sort of the younger end. It seems to be a spectrum on how they fit. Ask my dad and he freaks out. He leaves a piece of paper when the delivery person comes. So I think there's a whole limitation. So it's a very, again, it's a scaling process. In terms of data sets, one other data sets, we've talked about this earlier, is also patient-generated data, but on a subjective basis. Again, particularly you said in the behavioral health side, which is how do you feel? As an example, each person responds differently, and it's key because you may have all your device-related data the same. John may have the same device, but we respond to that answer differently, or do you feel stressed? And that adds a whole new layer, a whole new dimension. And the challenge is, how do you take subjective data and make it structured and validated so that it can be used and tied into the predictive modeling and the AI? But I think that becomes a crucial area. And sorry, tied to that last challenge from the earlier question you asked me about what was surprised in terms of the devices, is a CMS population where you have shared devices. So you may have a cell phone or a device that's shared amongst the family. So it's also determining who is wearing that device or using that device at that time in terms of the data stream that you're receiving. Discuss.
Well, I'd love to make one point based on Howard's comments, because this issue of quantifying the patient or consumer experience using digital technology, I think this is so critical. It reminds me a lot of the challenge of over a decade ago when patient-reported outcomes were being sort of refined, and you saw some guidance from the FDA, and you've seen that evolve into COAs, clinical outcome assessments, and so this is, today it's this sort of the state of the art when it comes to measuring subjective patient experience through, generally speaking, validated questionnaires. So I don't think that's going away. I think that serves a very important purpose. But here's what I found. When you go out to insurance companies and even big provider institutions, like I mentioned before, and you're talking about the benefit of a drug or a med device that's been measured by a validated PRO instrument, they acknowledge that it's validated and it's published and may even find its way into the package insert in the label. But then more often than not, they'll say to you, we don't use that in the real world. So that scale that you're pointing to that demonstrates the value of your medicine, that's hypothetical. And maybe it was true in your experimental setting, but there's no way to prove it in our world. And it's just not part of our clinical workflow. So segue to what Howard was saying, I think that these tools now are the next generation of quantifying the patient experience in a way that will one day be recognized by the FDA. I expect to see it in labels, and I do expect payers and provider institutions to recognize it and perhaps even contract on it with pharma companies so they get paid based on what happens to the patient that's being measured by a sensor or a wearable.
John, great points. Nathan, do you want to progress, or can I step in for a second?
Go for it. Go for it.
When John was talking, I was thinking about two very important things. I'll give you an example. In UK, for example, the GPs that work for the public service, they get paid on performance. The more patients they see, I don't know how it works, but the more patients they see, the better. So for example, they see 150 people a week, 30 people a day. And that's in his own right is the wrong thing to do, because you're not giving any attention to to data, well, to the patient in the first place, because you try to see more patients, yeah, but also it goes completely against to what we as trying to achieve in the industry, to bringing new business models, bringing the technologies up to being used, to be scalable, to be mass market. Even though not we are now, excellent point by John, because now we have these technologies accessible to us, but it seems like we creating the business models and the health systems completely against what we should be doing, you know. And this is just an example. It's like, okay, we have access to wearables, now the prices are going down. What we could be doing or should be doing is trying to have more people to use wearables, embed that in our health systems. We can get the bracelets now for $20 or $30, but no, we actually pushing that away. So wonder why we're talking about prevention for the last, I mean, decade or 2-3 decades at least that I'm alive, and it never really materialized. I think now we come to a stage that really something needs to shift in terms of like, okay, the responsibility is always going back to the individual, isn't it? I'm responsible for my health, if I get a wearable, if I sleep well, but also we need a major shift in healthcare that really, I mean, enables us to bring the technology and then leverage their potential. Otherwise, as John mentioned, is always going to be done on, I mean, a very reduced scale in terms of potential. We might try things out, but we never really maximize the potential, which is very unfortunate.
Yeah, thank you, and that's a really good point. And just kind of a final like comment on this discussion specifically. It's like we're always talking about, as Howard kind of kicked it off for us. It's like we have this data, and it's like, how do we actually translate that to evidence? And John, I know I promised we'd get back to the real world data side of the equation, but it's like you said, we have all this data, we have like all these things, and like a couple things that are going on are pretty backwards. But can you actually like touch a little bit more on like, how do we actually take this real world data and that we're getting from these sensors and these wearables, and how can we effectively translate that to actual evidence that's actionable, so that there's actually some more long-term value, rather than really just kind of narrowing that that scope of capability?
Yeah, thank you for the question, Nathan. And I think we've already had a pretty good preamble on the discussion because of the challenge of how do you quantify something subjective. But you know, one thing I recognized when I was in my innovation role was there's no shortage of tech companies and startups that have very compelling tools that that do a better job of measuring experience. And it could be like a sensor or wearable, it could be a robot. There's so much happening in the mental health space, and yet most of these tools weren't surrounded by science in terms of measurement. They were really engineering marvels in terms of their design. So they had tremendous upside in terms of what they could do, but not a lot of thought around, okay, how do you harness the power of that? So you have to think like a health services researcher or a epidemiologist in my case, but you need to think about, okay, I need to design experiments to actually measure in a valid and reliable way what's happening here. And I need to state a hypothesis. I need to measure whether or not the hypothesis was rejected. You know, is there some kind of baseline assessment that I want to do? What are some of the competing factors that could contribute to an outcome outside of the technology that I'm using? So you just need to subject it to studies, and I think that's beginning to happen. And there's a company that did a deal with Merck not too long ago called Evidation, and they've been trying to kind of put, I think, some structure to all the apps that are available out there, and kind of curate them in a way and figure out which ones have been studied in a trial. and which ones have been studied in an observational study, and which ones have not been studied at all. And, I don't know if that's the end all be all scorecard, but I think the idea of taking a technology, generating data off the technology, but then subjecting that data to a rigorous study design, just like we would a drug or a medical device, is the way to go.
Awesome. Thank you. And I know we're coming up on time, and I know we have to kind of transition. We have to transition to Jerry pretty soon. But I also wanted to give everyone the opportunity, if there's any other comments or insights or any sort of last words before we end this session today. Is there anything else that you are just dying to share with the audience, or any questions that we haven't addressed quite yet?
Just in summary, in terms, I think we talked about it, and John certainly summarized it quite well in terms of, and there is that wealth of data out there. So now the trick, and lots of toys to collect the data, but no standards against all those pieces. And so I think the biggest challenge over the next period of time, whatever that is, 2-3 years, let's say, in terms of, because everything's expedited speed-wise, is finding a way to standardize that data and make sense of it all. And to your point, to be able to have systems to go, okay, we've got these 10 streams of data, all we need are these 2 for the moment. And so the means of being able to, for systems, however it's done, to say, okay, this is what we need right now for that expeditious response. Because all what this does is lead to precision medicine, but it's only valid if you've got the valid data and structured data that actually means something and it's actionable. So I think it's actually probably a bigger challenge than we've actually had leading up to this point, which is having all these various solution sets and devices. The bigger challenge is, okay, sometimes you sorry for what you ask for, be careful what you ask for. We asked for it, now what do we do with this? And I think that's going to be an interesting challenge. I think the result when we make the other side is going to be, pretty spectacular, but there's a bit of work to do to get around this mountain we've all created.
Awesome. Joel, John, any final comments?
No, maybe what I'll just say though is Howard triggered a thought, was that many of these technologies can contribute to algorithms, and it's just something to note. And maybe we can have a follow-up discussion one day. But the algorithms have taught us a lesson, that you have to be careful for what you wish for, as Howard just said, is that you have to be thoughtful of the data that's fueling those algorithms, that it's representing some generalizable population, and that it's holistic data. Otherwise, you're going to have a biased algorithm. So it's just something to be thoughtful of, because the algorithms are a use case of these digital sensors and wearables.
And very quickly from me, I actually am a co-author of a book, and I wrote a chapter on my vision that the combination of wearables and artificial intelligence will be the true game changer in healthcare. We are heading in a good direction, but we a bit short still. I think we are at the beginning of that journey, but also just living with my vision that I believe the wearables can change the world. And we're seeing now wearables permeating many, many industries. But of course, in healthcare, we're talking about patients, is crucial to have good tools for people to improve their health.
Awesome. Well, Howard, Joao, John, thank you guys all so much for joining us today. Awesome conversation. Jerry, next time we'll have to give us another 45 minutes, because this is all afternoon. So.
But yeah, no, really wonderful, guys. I could definitely listen to you guys for at least another 45 minutes. Talking about all the different things that you brought up in this panel. But like I like to say, with all the panels we've had so far, the conversation doesn't have to stop here. At the summit, we have all these different networking rooms where we can continue the conversation. And I just created a networking room for the role of patient-generated data in population health management that the guys are talking about here. So feel free to visit the networking rooms within the platform and carry on the conversation. Sincere thanks and an honor, gentlemen, to have you all on once again. And Nathan, wonderful job hosting after a long hour of sitting there listening to presentations. So thank you very much as well. So feel free, guys, to connect with Nathan, Howard, Joao, and John, and you can all take a quick break before Stan comes back to our 2 o'clock panel. So have a great day if you are leaving, and we'll see you later in 10 minutes if you are staying. Thank you, guys.
Thanks, everybody.
Thank you.